Hi everyone. I am now giving you an additional input in relation to curriculum development, this time in the context of outcome-based education and competency-based curriculum. If we are to develop curriculum, or as you are now working on your curriculum, remember that we're basically using the competency-based education model. And you know that the competency-based education model was endorsed by the health professions for a New Century Lancet article. And what you will note here is that basically our traditional is related to just this particular framework. But as we go to competency based, we realize that the competency will have to be influenced or be influenced by the need of the healthcare system. And everything will have to come from the competencies, meaning assessment and curriculum will have to be based on the competencies that you have identified. So what are our consideration when doing competency based? We all know that it will again, if this is a review, this was presented in my original other in my other slides. We again we go back that all our curriculum effort should be related to what we value and what our educational goals are. And these educational goals, as you remember, would have to be influenced by the basic paper you're using for the design, health indicators, health futures, and best practices. For example, if you talk about AMBES program on diabetes, so they're probably talking about what would be the best practices here. What is the future in the treatment of diabetes? What are the health indicators related to diabetes and the basic paper related to or your organization? So if you're into surgery, the same thing. You go into the best practices, health future, health indicators, and basic papers. And this actually will define the rationale section of your curriculum design, if you remember that. And of course, from that, educational values and educational goals should influence your decision making in relation to defining the competencies. And we know that the competencies should come from the roles and responsibilities. So basically, your competency assessment is a again for using the OBE perspective backwards. So you have the role and going the role, and you go backwards to this particular competency. So if you follow this, it will be basically this, this, and this. Okay, and that is your supposed to be your process. Now, if you again look back in the context of rationale and for example we're talking yesterday or last session about um, the impact or the curricular effect of your proposal and see remember that your proposal will be influenced by or will have to be in relation to the health system, the epidemiology. So who do you ask here? So you can review your stakeholder, you can talk about POH thing, technological innovation. What will be the implication of the course in relation to the current technological innovation? Professional differentiation, for example. Will your curriculum have impact or will it affect other professional groups like the debate going on in terms of, for example, medical act in relation to optometry, for example, and ophthalmologists? Will there be, let's say, crossover of profession between the two? This is important because the differentiation would impact on the curriculum development and implementation. So you'll probably experience complaint or you'll probably receive complaints from other professionals. why are you dealing with this content area? This is our content area. I think some of you are familiar with this and experience some ongoing discussions related with other professions um, about the limits, the coverage of individual practice. It is also important for us to realize, for example, that our courses will have to more or less look into this dynamics of WHO primary healthcare concept. What you will notice is that the needs of the population globally would be very basic, and to be able to perform these basic competencies, we need to have this particular other principles related to service provision, like intersectoral and agency collaboration, community participation, and reorientation of the national healthcare system. If you notice, as I said earlier, really, these are really very, very basic. But if you look at our curriculum design, they are so sophisticated. At the end of the day, when you deploy your doctors to the community, what they know basically would probably not be congruent with this. So they end up not being able to perform the basic primary healthcare work that they are expected of them in the community or in the provinces or the town where they're supposed to be deployed, like our doctors at the barrios. They have to come back for regular training because a lot of the things they are supposed to do as primary care physicians in the rural areas are not present because or they are not prepared for them because they were never really trained in that area. The curriculum is not addressing the primary healthcare requirement of our healthcare system. So let's go back to the competency development framework. So you have here, you said the curriculum design, and it's just another view of the competency development or competency analysis. You talk about starting here with your terminal competency, going back, going back to the part and that we discussed about. And when you do that, this kind of analysis from here to the end here in the enabling competencies, we're talking of curriculum design. You talk about probably the most terminal will happen in year 4, and the basic competencies or the enabling competencies will happen in the lower years. In terms of instructional design, you know that if curriculum design talks about this direction, instructional design talks about this direction. The issue is what will we do to achieve that, and eventually reach that. So again, it's like the logic model. This is the why, and this is the how of your program. So let's say, for example, the what and the why. You can say that the first in year 4, you want them to be able to manage common ambulatory conditions. And in year 3, you provide them with the enabling competency so that they will be able to perform. So if they can formulate that, probably they will do that. So you see, from manage to formulate a complete assessment, and to be able to formulate assessment, you need another set of competencies. Like, for example, to be able to formulate a diagnosis, you need to be able to interpret arterial blood gas, analyze the significance of arterial blood gas in the context of this terminal competency, probably read an ECG and identify life-threatening conditions. So that will happen in second year, like in your pathophysiology integrated. And then in year 1, to be able to perform the terminal here, so year 1, this is another enabling, you gather comprehensive PE, right? You demonstrate mastery of science concepts here, mastery of science concepts. So if you know this, 2, you know that in first year, then you can move to the second year, going into pathophysiology, you going into clinical, and eventually integrate them into the terminal competency, which is managed. You see how the the, the terminal competencies, or the verbs, the dimension of the verb would be going up from mastery, which is of course knowledge, understanding, to applying them here in the second year, to probably the to here in the second year level. You say probably it will be remember and understand and apply, but as you move here, you're going to evaluate, analysis, and evaluation, and here you're going to already create, right? Create your diagnosis or create your management. Okay, and that will be the how inside. So we know that the CHED mandated several outcomes: clinical competence, communicating effectively, leading and managing healthcare teams, engaging in research activities, collaborating with interprofessional teams, utilizing system-based approach to healthcare, engaging in continuing personal and professional development, adhering to ethical and professional legal standards, and of course demonstrating nationalism and internationalism. So if come to think of it, this will, as I said, this is a CHED mandate. So therefore, this will be your terminal terminal outcomes or terminal competencies. And again, move backward probably. This is what should happen in fourth year. But what will happen in first year, so that you can go to second year, third year, and eventually being able to perform the terminal competencies. As you notice, um, all terminal competencies should be more or less integrated with all other competencies. So this is common. You can be clinical competence in surgery, clinical competency in pediatrics, and sort of thing. Communicating to adults, communicating to children, communicating to parents. It could be again leading um, surgical team, leading a health system team in a local government unit. So these are all things that you should be able to use as basic for understanding of terminal or curriculum development. So in terms of example of terminal competencies in a workshop, for example, some of the students, some of the participants in the one workshop listed all this, but you notice not all of them are of the same level. Like gather a comprehensive history, right? Is different from managing common ambulatory conditions. So if you look at that, you need to be able to gather this first before you can manage. So the logic is, oh, okay, when you are preparing all the competencies, you can probably pre-list them like brainstorming, but at the end of the day, you should be able to um, organize them in their own hierarchy. That's why we call it also hierarchical task analysis. So from again the same here, one group manage common emergency cases, uh, list down diagnostic, observe changes in patient, aspire to be a good professional. So these are all related to that particular competency issues. See, interpret, analyze common laboratory tests. So this would be in relation to, for example, here this will be needed to be able to manage again, or to make a to manage here, to interpret basic laboratory protocols. And there you see that. So this relates later on to your formulation of intended learning outcome. Just a quick demonstration of how the whole thing has changed from 1956 to 21. You notice that before our highest is eval here. Now evaluation is here in the 2001, and we added here the highest, which is create. Actually, this is supposed to be synthesis here. So they put synthesis using another word, which is create. So because if you notice, these are what do you call it, evaluation, synthesis. These are noun, right? And here should be supposed to be here, supposed to be verb. You notice that down. So you verb. Here, verb form. See? So analysis is the noun and analyze. Why? Because it's really competency, which is outcome. Okay, that's why you use the verb form. So make sure that your taxonomy framework will be the new one. And we all know this already, so I'll go to the next just to again review some of the terms we use here. Yeah, I think you can access a lot of them in the internet, so you can use them. This is the way you map your curriculum, for example. So you have here, as you notice here, when you map all your courses. If you're using modular, for example, like this is CVS module, respiratory module, renal module, blah, blah, blah. And then all of these courses will have to be analyzed in the context of this CHED terminal competencies. So when you demonstrate clinical competency, CVS module, probably this is first year, you notice it is a map for first year, and probably they just going to learn. But since we are now integrated, more often like demonstrate clinical competence in cardiovascular in year one normal, because you have here pathologic. So for example, you the reason why they're using LPD already here is because you are already integrating, for example, if you're in the module of cardiovascular, you're already integrating ECG, reading, and even recognizing 3D echocardiogram results, for example, as you study the basic pathophysiology of the heart. See, so therefore it's integrated, and hence you can go really LPD at a particular level. When we say LPD, that would mean your module will go through all the process, meaning from learning, practicing, and demonstrating. It's like saying that from normal or from learning concepts to practicing application of concepts to demonstrating how the concept will be used in real patients or simulated. So this is in third year almost the same, especially if you're in the integrated system. Um, when we were organizing, for example, the Bicol Medical University College of Medicine, this is how it looks like in general framework. So you have year five. So the recommendation really is year five should, which is now internship, should now be part of the course, and therefore students will graduate after the fifth year. I think St. Luke's or La Salle is also doing that now. Uh, so you notice here, Doctor of Medicine, organ system integration, normal. Then you move to organ system integration, pathologic, organ system integration here, but this time you go already on the clinical grouping. So now you use everything because clinical medicine will now be in terms of like the modules would be like OB, pedia, etc. And then they go to practicum in clerkship, and then another guided practicum in post intern um in post intern, what you call it, internship program. But since the school also would like to develop what we call the double degree program, they proposed a master in health management focusing on disaster management, because this was a Bicol University proposal. So you notice they also along parallel lines. They also some of the proponents are interested in integrative medicine, so they included also like acupuncture, traditional medicine, as part of the parallels. And applied research will not start at the later years. Actually, as early as first year here, students will already be doing applied research. So they will be doing a lot of research till the end of the program. So be reminded that integration should be at all levels, both vertical and horizontal. There should be a community-oriented program components for every subject in the program. I think it's also a requirement of, and I would like just to add also developing the attributes of a human medical practitioner. And this would be like equipped with necessary clinical competencies, engages in shared decision making, respect patient rights, establishes trust, integrity, compassion, and empathy. These are attributes. So therefore, don't say this will be your at the end of a course or at the end of a subject. You don't necessarily do that because this can only happen, or this will have to be developed progressively from first year to fourth year. This is what we call developmental goals. So you don't expect them to be probably demonstrating all the competencies at the highest level, but they develop through time. So you make sure that all these attributes are being addressed by each of the courses. You don't just put humane when you're in clinics. You can be humane when doing anatomical studies, for example, or even when doing animal experimentation. So what I'm trying to say is attributes would be the ultimate description of a doctor that we want to graduate. But attributes are not really competencies, but rather characteristic of the doctor that you want to develop. So, in summary, development of the health profession should focus on not just on subject matter, but also professional disciplinary knowledge. That's what the last slide that we discussed. And should also focus on what is known as improvement knowledge, meaning you go from okay knowing about it's more like effective knowing about the correct behavior, but it would take some time, 2 years before the appropriate behavior can be demonstrated. It will not happen over time. These are called improvement or developmental objectives. Okay, thank